introduce one of our senior residents, Archana Trivedi. And I just wanted to let you know a little bit about her. She was born and raised in India, and she completed her medical school at North Bengal Medical College in India. And after that time, she completed a full psychiatry residency program in India and then went on to work as a clinical psychiatrist for a couple of years. And then she came here to the U.S. and joined our program. We were lucky enough to get her in 2008, and since that time, she has been an exemplary resident, has really just excelled. She's earned both the junior and senior resident awards for overall performance during her time with us. Currently, she's one of our amazing chief residents, and I've had the pleasure of working with her and seeing her talent and dedication in this role. She's always had an interest in the stigma associated with mental illness and how it can affect the medical care of patients. And under the supervision of Dr. Nick Brightboard, she was able to complete an observational study involving the stigma with mentally ill patients and HIV-positive individuals. And she'll be presenting those findings to you today. All right, so let's introduce Dr. Trivedi.
Good afternoon, everyone. Thank you, Dr. Macy, for a wonderful introduction. Welcome, everyone, to this Grand Rounds. Today, I'm going to talk about my research project, Stigma Among Individuals with HIV or Mental Illness. Stigma is the word which was derived from word mark. Mark was made on the body of slaves centuries ago just to distinguish them from others. Later, Goffman defined stigma as the process by which the reaction of others spoils normal identity. There are about 3 forms of stigma: a physical form of deformity or undesired differentness. It could be because of any kind of illness like leprosy, rheumatoid arthritis, or even congenital deformity, an association with a particular race, religion, belief, etc., and the fact of mental illness or any other illness which is viewed bad by the society. Stigma is seen in many chronic illnesses, causing much suffering to those who are stigmatized. It has strong negative implications for public health efforts to combat the disease or conditions concerned. Stigma related to chronic health conditions such as HIV/AIDS, leprosy, tuberculosis, mental illness, and epilepsy is a global phenomenon. Well, let's pause for a minute and think, as a mental health providers, why should we think about stigma? Our job is to diagnose as per DSM and treat. Why should we care if somebody is embarrassed or ashamed to come to us? Unfortunately, our job is not that simple, because the major goal of mental health policy is to reduce barriers to service utilization. Many authors reported stigma as a key barrier to mental health care. Surgeon General concluded, for our nation to reduce burden of mental illness, to improve access to care, stigma must no longer be tolerated. Stigma can have several effects on individual. Few listed here are psychological stress, which can lead into depression and anxiety, various participation restriction, for example, unable to participate in treatment program and care services. Therefore, it's leading to advancement of the disease process and increased risk of disability. Also, in HIV individual, there is a risk of unsafe sex practice due to concealment of diagnosis, which is again due to stigma. There could be a sense of isolation and emotional distress and self-hatred, as reported by several authors. The aspect of health-related stigma used for assessment can be grouped in 5 categories. Number 1, the experience of actual discrimination on the part of the person affected. Number 2, attitude towards the people affected. Number 3, perceived or felt stigma. Number 4, self or internalized stigma. And number 5, discriminatory and stigmatizing practices in health services, legislation, media, and educational materials. Within each of these areas, different assessment methods had been used. Therefore, it was difficult to say that out of these 5 components of health-related stigma, which one is affecting the care-seeking most. Care-seeking is a process that is influenced by social and cultural factors. The importance of stigma as a barrier to mental health and HIV care is consistent with theoretical model of health-seeking. The studies have demonstrated that attitude and belief about these illnesses has significant influence on health-seeking or care-seeking behavior. For that reason, we focused our study on perceived stigma because perceived stigma is a key social factor that affects care-seeking. To define perceived stigma or to understand perceived stigma better, perceived stigma is the extent to which an individual perceives the public to stereotype and discriminate against a stigmatized group. A community-based study found that about 24 to 29% of individuals with an apparent need for help reported being afraid of seeking care due to perceived stigma. This study was done in 2008. Coming to the stigma in mental illness, unfortunately, the stigma of mental illness strikes with double misfortune. Number one, there is a negative public opinion regarding course and outcome of illness. There is a general belief that all mentally ill are dangerous and therefore nobody should hire them. Number two, mentally ill patients living in such culture may accept these notions and may suffer low self-esteem and self-efficacy. All studies done on stigma in mental illness revealed negative attitude towards mentally ill. However, none of these early studies explored stigma in mental health consumers. Therefore, all these early studies were based on public opinion. Relatively few studies have sought direct information from mentally ill patients, and those studies revealed that mentally ill patients experience themselves as stigmatized. They reported being treated poorly by public, encounter rejection and discrimination, and they suffer demoralization and reduced life satisfaction. They also said that they have to employ specific strategies to protect themselves from rejection and discrimination. Unfortunately, little attention is paid to how stigma may affect well-being and health. Coming to stigma in HIV and AIDS individuals, there are 3 aspects of stigma in these individuals. Number one, blemishes of personal character. There's a general belief that people are responsible for their conditions, therefore they do not get any empathy. Stained social identity, a belief that infected people are contaminated and tainted, so nobody wants to touch them, nobody wants to share any belongings with them. Or any physical deformity or defects which could be due to lipoatrophy. Various research have shown that AIDS stigma is barrier to HIV prevention, testing, and counseling. Although there has been recent attention given to the issue of stigma, both internationally and domestically, and calls to eliminate stigma towards people living with mental illness and HIV, there's little consensus about how to confront and eradicate stigma beyond providing education. Our study was focused on identifying some of the factors which might influence the stigma and therefore help us dealing better with stigma. Some factors which could influence stigma: it is well known that different people react differently to stigma, but we do not know what determines their different reactions. Some research have suggested that personality factor can play a role. Also, different diagnoses can have different reactions, and few studies suggested that low self-esteem and self-efficacy can influence the reaction to stigma. The goal of this study is to simultaneously examine the level of stigma among individuals with mental illness and individuals with HIV to address 3 specific aims. Number 1, compare severity of stigma among people with HIV and people with mental illness. Compare the association between stigma and well-being among individuals with HIV and individuals with mental illness. And also to look into how do personality factors influence the relationship between stigma and well-being. The study involved the distribution of survey concerning specific stigma and discrimination experiences. 50 participants were recruited from 50 adult patients were recruited from University of Arizona Medical Center South Campus Outpatient Psychiatry Clinic, and 50 adult patients from UAMC University Campus and South Campus Infectious Diseases Clinic. Demographic information regarding race, ethnicity, occupation, education, and socioeconomic status was collected from all 100 patients. Following questionnaires were used to rate current health status, experience of stigma, life satisfaction, and personality factor on all 100 participants. The first one listed there is RAND. It is a self-report measure of current health status. Only one question was used which asked to rate current health as compared to 1 year ago. It was rated on a scale of 1 to 5. Higher scores suggested poor current health. This question was used because it is a predictor of all-cause mortality. The next questionnaire was stigma questionnaire. A 9-item subscale was used, and it asked people regarding interpersonal experiences as consumers. It addressed such topics as specific treatment by others, negative things seen or heard about mental illness, and fears and behavior related to disclosure of status as consumers. It was rated on a scale of 1 to 5. Higher scores suggested high stigma. Next is satisfaction with life scale. Satisfaction of life scale is designed around the idea that one must ask subjects for an overall judgment of their life in order to measure the concept of life satisfaction. Individuals indicated their degree of agreement or disagreement on a 7-point Likert type scale. Higher score suggested good well-being. 10-item personality inventory. This was administered to assess Big 5 personality traits. Coming to Big 5 personality traits, many researchers believe that there are 5 core personality traits. Number 1, extraversion. This trait includes characteristics such as excitability, sociability, talkativeness, assertiveness, and more emotional expressiveness. Number 2 is agreeableness. This is the trait with trust, altruism, kindness, affection, and other pro-social behavior. Third one is conscientiousness. This includes right level of thoughtfulness with good impulse control and goal-directed behavior. The fourth one is emotional stability. It has traits like stable emotion, less anxiety and moodiness, and low irritability and sadness. And the fifth one here is openness to experience, which has the trait features like imagination, insight, and broad range of interest. All participants were given the choice of completing the questionnaire and dropping it in the secure Dropbox. The completed questionnaires were collected by me every week. Subjects at both clinics completed questionnaires upon presentation for their regularly scheduled appointments. In statistical analysis, the rate of missing data was 4.4%, which is actually pretty low. Missing data replaced using multiple imputation, and multiple imputation has been identified as the best strategy to deal with missing data. Coming to the descriptive analysis, the sample was predominantly Caucasian, 66% in mental illness and 70% in HIV. The dominant ethnicity was non-Hispanic, 50% in mental illness and 60% in HIV. All the recruited individuals had some college education. The mean years is 14.1 in mental illness and 13.47 in HIV. And socioeconomic status was calculated using International Socioeconomic Index of Occupational Status, which had score in range of 0 to 100. Higher scores indicated high socioeconomic status. Our samples had the score in the middle range. In mental illness, it was 53.02, and in HIV, it's 49.02, indicating middle status. Coming to the predictor variable and outcomes, the two predictor variables were stigma and the personality traits. I'll come to the personality traits in a bit. Stigma was scored from on a range of 1 to 5. Higher scores indicated worse stigma. Both groups scored somewhat in the middle. So mental illness has 2.51 and HIV scored 2.78. However, difference between these two was statistically significant. And as we can see that HIV people scored higher than mentally ill people. Well-being was rated on a scale of 1 to 7. Higher score reflected higher well-being. Both groups showed mid-level of well-being, 3.86 for mental illness and 3.49 for HIV, and the difference was not statistically significant. RAND is the measure of current health status, rated on a scale of 1 to 5. Higher score reflected poor current health. Our group showed average middle score, and the difference was not statistically significant. Coming to the personality traits in both groups, in general, people with mental illness scored higher on all personality traits except on agreeableness as compared to HIV group. But the two which was statistically significant between the two groups was emotional stability and openness to experience. Others were not significant. And personality factor was rated on a scale of 1 to 7. Now looking into the stigma into groups, these are the 9 questions, and higher score on all these questions reflected high stigma. In general, HIV group have scored higher than mental illness group in almost all the questions. But the 2 questions which were statistically significant between these 2 groups were one regarding avoiding telling family members, on which HIV scored more than mentally ill, and one regarding avoided by others, and again HIV group scored more than mentally ill group. Now looking at the entire sample, all 100 patients, we looked at the association between descriptive variables, predictive variables, and outcome variables. The descriptive variables are education and socioeconomic status, and the outcome variables are well-being and RAND, and predictive variables are stigma and the types of personality trait. Let's first look at the association between education and socioeconomic status with well-being. As we can see here, both education and socioeconomic status is associated negatively with well-being, meaning high socioeconomic status is associated with lower well-being. Education and also education, high education and socioeconomic status is associated with lower well-being. Looking at the association between education and RAND, high education is associated positively with RAND, meaning higher education is reporting poor, is having poor self-reported health. Coming to stigma with well-being, the association with stigma with well-being is higher the stigma is reflecting higher well-being. This was one unexpected finding. Stigma is not associated with RAND. looking at the personality traits and association with well-being, all personality traits except agreeableness is positively associated with well-being. Therefore, higher well-being in these personality traits. Looking at the association between personality traits and RAND, none of the personality traits are associated with RAND except agreeableness, which is positively associated with RAND. So higher agreeableness is high RAND, and again, high RAND is bad. It's poorly reported self-help. We also looked at the interaction in between dependent variable, which is well-being here, and two independent variable. One of those is stigma, and other is the two study groups, mental illness and HIV. And as we can see this interaction, as stigma is increasing in HIV group, well-being is increasing. But same is not true for mentally ill group. So increase in stigma is not causing any increase in well-being in mentally ill group. Here we are looking at interaction between RAND and stigma in those two groups. In both groups, there is no interaction between level of stigma and RAND scores. We looked whether personality factors would moderate the relationship between stigma and our outcome variables, which are RAND and well-being. The only one which was statistically significant was interaction between RAND with extraversion, and only in mental illness group. As we can see here, stigma is associated with increase in score of RAND, but at low stigma, the score for both high extraversion and low extraversion is same. As stigma is increasing, we can see the score for high extraversion on RAND is lower than low extraversion. And again, to remind you all, high score on RAND is bad. We do not want that. So therefore, we can say that high extraversion buffers negative aspect of stigma. In two groups, there was no significant difference in race, ethnicity, education, and socioeconomic status. There is also no difference in level of well-being and RAND in two groups. Higher education and socioeconomic status is associated with lower well-being. Higher education also associated with worse self-reported health. In mentally ill individuals, this group reported lower stigma as compared to HIV group. These reports somewhat looks encouraging. For example, mental illness folks have scored low on questions such as being treated less competent or being avoided by others. These findings are not consistent with some of the early studies done by Wall in 1999. That study reported high score on being treated less competent as compared to this study. This group also showed higher emotional stability and greater openness to experience as compared to HIV group. Based on these results, we can say that high emotional stability and openness to experience is protective towards experiencing stigma. This is the only study to look into relation between stigma and emotional stability. High extroversion buffered the effect of stigma. The relationship between high extroversion and stigma is also not well studied. In this study, people with high extroversion showed less stigma. Coming to the interpretation in HIV group, increased well-being is associated with more stigma. This was unexpected finding, and none other studies have reported this. However, there are very few studies which have looked into the relationship between well-being and stigma. as compared to mental illness group. This group reported more stigma, especially regarding being avoided by others and also not being able to tell the family members. Decreased conscientiousness and emotional stability may be associated with more stigma. This was also found in this group. There are few limitations to this study. Due to cross-sectional design of this study, the direction of relationship of different variables is not known. Also, age and gender was not collected. Therefore, it is not known if age or gender could have influenced the results. We did not examine the relation between ethnicity and stigma, and psychiatry diagnosis was not known, and also knowing the patient population at South Campus, possibly it was undersampling of psychosis. Based on these results, we can suggest some modification in treatment practices in both psychiatry as well as ID clinics. Promote extraversion in individuals with a mental illness. It may be done with social skill trainings. Also, thinking of promoting emotional stability in individuals with HIV, as it's done in DBT with borderline patients. And also, there is a need to increase psychiatry services in HIV-positive individuals. The reason why we need to do this is because it is reported that nearly 48% of HIV/AIDS individuals have psychiatric disorders. CHAID's study, which is coping with HIV/AIDS in Southeast study, revealed 38% of lifetime sexual and physical abuse, leading to PTSD, anxiety, depression, and borderline personality disorder in these individuals. Also, HIV cost and service utilization study reported 36% of depression in HIV/AIDS. Based on what I just presented, we all might agree that HIV-positive individuals do need psychiatric care. I would use this opportunity to let everyone know that UAMC Psychiatry Outpatient Clinic at South Campus is already working towards collaborating with RAN and White program of HIV/AIDS so that we can start providing psychiatric care to HIV-positive individuals. This is a big step toward the right direction. Some of the future directions suggested is it's worth exploring why is stigma associated with greater well-being. Also, out of 5 personality traits, why do only emotional stability and extraversion stands out? It's also worth looking into the factors which could influence emotional stability and extraversion. First of all, I would like to thank all the patients who participated in this study. My sincere thanks to Dr. Breitbart for his guidance and supervision at every step of this project. Thanks to Rachel Peterson for her invaluable help during IRB submission. And thank you, Glory, in helping to organize this presentation. I would also like to thank staff at ID Clinic. Patty, thank you for coming. Without whose cooperation, this was not possible. And Kelly at Psychiatry Outpatient Clinic South Campus in helping and cooperating with data collection. Also, thank you PGY3 and PGY4 residents at the Psychiatry Outpatient Clinic South Campus for your help in data collection. Last but not the least, I would like to thank the audiences, the ones who are here and the ones who are watching this grand round from the South Campus for coming to this presentation. Thank you. Any questions? Yeah.
You made that connection kind of fraction of society or social interactions as much. And when you were saying that how it's associated with perception of stigma, I guess that would be something that would be interesting.
Yeah.
Because it seems like people, I mean, just from what I remember, the people who had increased well-being were the ones who were feeling like they had increased stigma. So it could kind of be a reaction. Could it be like a reaction
Right.
to feeling like they're stigmatized and hence showing higher resilience?
And that was seen only in HIV group for some reason. So, and it's not reported anywhere. That was, we never expected that finding. So it's worth exploring that why these two are associated. Yeah. No, that was not, that diagnosis was not collected from HIV. Yeah.
Read the paper, but was it ever identified duration of illness
For HIV?
or either?
No, we did not know. Yeah. Right, yeah. Yeah. Yeah.
What percent of the HIV population were also diagnosed with mental health disorder?
In this group, we did not see that.
You didn't test that?
No, we didn't look for comorbid diagnosis in HIV.
Are you going to look at ethnicity?
We are, yeah. Before we publish, we are going to do that.
I had a question about the ethnicity there. It said African American was 6% of the population. Tucson is only, what, 1 or 2%. Do you also have the same disparity in the mental illness population?
So, as you can see, mental illness had African American 2% and HIV had 6%. Two or mixed races were 4% in mental illness and 8% in HIV. And others, we had a category others, and we didn't put Hispanic in race, rather we put Hispanic in ethnicity. So others are falling in 18% mental illness and 10% HIV.
That's pretty close to the population distribution. In HIV, it's known that there's a higher percentage of African Americans.
Yeah.
There's a huge disparity to the population. So that shows it there, but it doesn't carry through with mental illness.
Yeah.
The sample of the people with mental illness is probably not reflective of the general population of mental illness in Tucson, given
Right.
the fact that HIV clinics service a different payer group than mental health clinics.
We have Medicare, Medicaid, wide of uninsured people. I would say that we probably have the same kind of distribution of payer source.
So we don't do Medicaid in the mental health clinic.
Okay.
It's
Yeah.
primarily private insurance.
Oh, okay. So by this, it's if you're smarter, you should be mentally ill instead of having HIV. My education, my ear, the smarter should be infected. You have mental illness than to have HIV. That's a joke.
Any more questions?
I wasn't sure if I heard your explanation about the inverse relationship between socioeconomical status and well-being. Can you tell a little bit more about what are some of the explanations?
Okay.
To explain that?
This finding with increased education and increased socioeconomic status is associated with poor well-being. This finding was also found by some other authors. Let me tell you the names. Yeah, it's been found before, yeah. Yeah. The one thing which was not found is stigma associated with higher well-being. This was not reported.
Is this in both populations or just in?
No, it was just in HIV.
Oh.
Yeah. So when you see that interaction slide, you see here how the HIV people have higher well-being as the stigma is increasing, but not the mentally ill group.
Are there any theories as to why that might be the case?
It's not well studied, first of all. Personality factors and health status with stigma. There's very, very few studies regarding that. And all I can say, we never expected this, that we'll be getting this result. But
the education and SES were in both, was only in HIV also?
Yeah, it was in both.
Oh, in both?
Uh-huh.
Together?
Uh-huh.
So you also indicated that you would want to promote extroversion in individuals with mental illness.
Mm-hmm.
What would that look like, or what would you recommend or suggest?
Well, to promote extroversion, all I can think of social skills training. And that's why in future direction, I have a suggestion, like we should look into factors. What would promote extroversion? Or what would promote emotional stability? We know a little more about emotional stability as compared to extroversion because we already do DBT and all in borderlines. But
How did you measure extroversion?
how did we measure extroversion? So this interaction was done. Actually, the personality factors, what we did interaction with all 5 personality traits with RAND and well-being in both the groups separately. And none of them came statistically positive except for this one, extroversion. So that's why I have just one slide here.
Isn't it possible that post a diagnosis,
What's that?
after a diagnosis, maybe the patient do develop a degree of introversion?
After diagnosis?
Confounded.
Could be.
These are more or less trait type of personality.
Yeah.
Opposed to state behavior,
Right.
They do have some variability, so it's possible that of course mental health issues or stress will influence some of the personality characteristics that I mentioned, but they tend to be traits rather than state.
Mm-hmm. Yeah.
You submitting this for publication?
Yeah. Thank you. Any more questions? All right, thank you.